It's very hard to see the progress that's been made in the health system because there's constant attention on the deficiencies, on the difficulties, on the problems. And that's understandable. Patients and their families are anxious to make sure that they get the best possible health service. Those that work in the system highlight the difficulties and the challenges and the problems, and journalists do too. So with that single focus on problems and deficiencies, it's very hard to understand that progress is being made.
Hello and welcome to Memo to File, an Irish policy podcast produced by Luke Fehley and me, Tom O'Connor. Today we're speaking with Lily Collison and Professor Jennifer Ryan about the Cerebral Palsy Programme of Excellence. The 5-year initiative, due to finish in 2029, is improving care in Ireland for those with cerebral palsy, a group of conditions impacting movement and posture to varying degrees. The Programme of Excellence is advancing a national register and advocacy group in addition to supporting the development of a coordinated, evidence-based approach to care and research.
The ultimate goal is that Ireland becomes a world leader in cerebral palsy care and research, that we get to that standard and then we maintain it. I have seen things where we had good care but we lost it. So it's one thing, we need to achieve it and maintain it, that Ireland becomes a global leader. And Ireland is a great country in the sense that 5 million people, generally a single health system, and particularly for children, there isn't really private care. And if we can get it right for Ireland, I think what we achieve in Ireland could be copied in other countries. I think within Ireland it could be copied for other conditions, but Ireland as a country, I would hope that other people are knocking on our door in a few years.
All that and more coming up on this episode of Memo to File with Lily Collison and Jennifer Ryan. Lily Collison is actively involved across healthcare and disability. She co-founded and now serves on the steering group for the Irish Cerebral Palsy Programme. Jennifer Ryan is a trained physiotherapist and director of the CP Life Research Centre at RCSI. She is one of the 3 leads for the Irish Cerebral Palsy Programme, with a particular focus on CP in adulthood. Later, we'll be speaking with Junior Dr. Beth Mallen for our Digest segment, but first I started off by asking Lily Collison to outline how she got involved with the CP Programme of Excellence.
I'm the mother of a now adult son with cerebral palsy. He's, won't mind me saying, but he's now in his 30s. And I suppose I knew nothing about cerebral palsy when he was diagnosed, and learned along the way. When he was a child, we had excellent therapies in Ireland, like the service, and I'm talking about 30 years ago. We had a community physiotherapist who really understood cerebral palsy, and she was enormously helpful. And we had access to the Central Remedial Clinic, again, at the time, a specialist centre for physical disabilities. With the reconfiguration of disability services, we've kind of lost a lot of that specialism in cerebral palsy. And that's one of the things that we're trying with the programme to bring back. I remember when Tommy was 9, we went to the US for orthopaedic surgery. I would never have gone to the US for therapies because the therapies I saw in the US were as good as we had at the time in Ireland. Because of my experience with Tommy, he is now thriving in life, you know what I mean? He had the benefit of good care. I suppose I know the difference good care would make. And like, while Tommy is done for, I care about all the other Tommies and Thomasinas in Ireland. And that's what the programme is about. You know, it's having the evidence-based best practice care for cerebral palsy across the lifespan in Ireland.
Taking this from sort of the 0 to 1 in the context of the programme, was there a point at which you realised, Lily, that it kind of, that you could do something in that respect in terms of bringing around the programme?
When I retired from my career, I decided to go back and write the book I had always wanted when Tommy was first diagnosed, because even though reasonably, and I have a science background, I found cerebral palsy fierce complex to understand, and I can't act unless I understand. And I went back and researched and wrote a book. I went back to the hospital in the States where he had had his surgery and said, lads, if I research and write this book. Will you edit it? And which they did, right? And we published a book on Tommy's type of cerebral palsy. The cerebral palsy exists across the spectrum. Published a book on his type, spastic diplegia. And Jennifer had published a lot of research in cerebral palsy, but she was very disillusioned because there was very little structure around cerebral palsy. And I was saying, bide your time. And actually, sort of a number of stars aligned together that we developed this programme. And Jennifer was one of the first people I spoke to about the programme. And thankfully, she's one of the leaders of the programme. You know, it was just to pull together the expertise that are in Ireland. We could have a programme for cerebral palsy.
Mm-hmm. And I suppose Lily touches on it there, Jennifer, in the context of sort of maybe a disenfranchisement with the lack of a formal structure. Were there other avenues pursued that kind of to consider potentially doing something like this?
I think what the programme brings is that structure and the infrastructure and indeed the awareness, because I've been, as I said, doing CP research for a long time, and yet people in my own university don't know what CP is, or I work with really expert teams of clinicians, but it works because we have a lovely group of people who are interested in the topic, and then you hit a barrier when you're trying to influence people who don't have that same interest and expertise in the topic. And there is no mechanism of how do you get these, innovations we're developing, this knowledge we're generating. And we keep moving more and more towards implementation science because we're fed up of generating the knowledge of this is a problem and then no one picks up what the solution is. But still, when we're developing the solution, there's no mechanism of getting it into clinical care. And that's really what the programme has provided, that structure of how can we bridge that gap between best practice, what we know in Ireland, what we're doing, what we bring from internationally. We work with lots of international teams. How can we bring that in and actually get it implemented? And as I'm sure you know, it's health services research and health systems, that's the big gap, is that implementation piece. And I would say in the HSE, there is the mechanism for, clinical pathways through, at the moment, clinical programmes, but there's no CP programme. There's a CF programme, there's diabetes, there's epilepsy, there's a disability programme, but there's no CP. And without that, nobody even thinks about pathways for CP. Even that alone just shows there's a lack of awareness of what there is, and people don't know what they don't know. So the programme has shone a light on it.
Like I get an email, you probably get that same email every Monday. The research published, there's loads of research published around the world. We get an email every Monday with the updates. I care about it being implemented, right? And it has to be implemented in a very careful way. You can't just sort of rock up and say, I want to implement this. There's a good example in early detection where there was a clinical practice guideline published for early detection of cerebral palsy. And before this programme started, that people were getting the diagnosis of cerebral palsy around age 2 to 3, that sort of age. Through this programme now, we're now reducing the age of diagnosis, say, among high-risk infants. So that would be infants that would be born premature, low birth weight. But in high-risk infants, we've, through the programme, been able to reduce the age of diagnosis from an average of 2 years to an average of 6.5 months, just through the programme alone, And you could say, well, what's that matter? Early diagnosis leads to early intervention. And the brain is at its most plastic, it's most able to rewire in the first 1,000 days. And that's up to age 2, from conception up to age 2.
Lily, it's interesting how you mentioned that you came across Jennifer through the research for the book and stuff like that. Was there an element of sort of assembling the football team that you wanted to do it?
Yeah, and I like that you mentioned the football team because you just reminded me. I regard this programme that we're a soccer team, and I have no particular interest in soccer, but we're like a soccer team for this programme. So if you think of 11 positions, and there are 11 on a soccer team, isn't there 11? I'm correct, is there 11, on a soccer team, but that we each play different roles. The aim of the programme is to improve care for individuals with CP and their families, to improve care, right? If that's our ultimate aim, we do that through research, we do that through education and training, we do that through clinical implementation, we do that through advocacy, all those pillars, we do that. But we each play a part in the programme, but we all work together. But it's no individual's performance that will guarantee the success of the programme. It's a team performance. Say Jennifer working in adults, we have Deirdre Murray down in UCC and Geraldine Boyle, and Deirdre leads the early detection, early intervention part of the programme. Denise MacDonald in Trinity leads the children and adolescents. Geraldine Boylan is doing a huge, Geraldine and Deirdre, a huge Elevate programme of research. And it's all of us working together. But a very important ingredient in this is the families. And the families have now formed. Hard to believe when you think there's Epilepsy Ireland, there's Down Syndrome Ireland, there's all these. There was never an Irish-led family group for people with cerebral palsy. And the Cerebral Palsy Ireland has now been formed, which is the family voice of people with cerebral palsy. So in the spirit of nothing about us without us, we're working closely with families.
And the teams are a big part of that. I suppose with the football teams, yes, there are 11 on the team, but there are many on the bench as well, to come on in the background.
Yeah.
I suppose when you were assembling the team, how did you successfully manage to convince the talent, so to speak, to come on board?
I actually think there was a huge hunger. I have to credit the Cerebral Palsy Foundation in New York, who helped get the programme off the ground, but now the Irish team are leading it going forward. But when we first raised the idea of a cerebral palsy programme, there was so much interest in it because the gaps, everybody saw the gaps. Like Jennifer had seen the gaps. Families were delighted, but also the clinicians, the researchers, and all we had to do was get organised.
I found personally one of the real benefits come out of it is working really closely with Denise MacDonald, who's, Lily said, is the children's. She's been appointed as an associate professor in cerebral palsy in Trinity. Before that, there was no dedicated academic position or clinical academic position to CP. And so it meant when we were working with clinicians, we were just relying on goodwill. They were full-time clinicians. We were asking them to join meetings to help us on projects in their spare time, basically, which they were happy to do. But you can't rely on that to really make change when nobody has dedicated time to think, let alone to actually do things. So having Denise in that dedicated role is so important, and us working together has opened up so many more avenues beyond the research and into that kind of clinical implementation phase, both in terms of her clinical knowledge, but also the relationships she has across the HSE and across disability services. So, I mean, I was, delighted to have the opportunity to work with other experts in CP. And as I said, I was getting a bit frustrated with doing research and not seeing it go anywhere. And this is the opportunity to actually implement it across the system.
You had great allies in the form of, let's say, Jennifer and yourself, Lily, but I suppose, did you also have to convert blockers or potential blockers into allies along the way, or was there a lot of...
No, I suppose the lucky thing, we were able to bring philanthropic funding to create the positions at the universities, and I suppose that was a game changer, the fact that we could create positions at RCSI, Trinity and UCC, that there was philanthropy for those positions. That helped enormously. We're sincere in what we're trying to do, and people, I have to say, it's blockers, I don't think so. No, it's a lot of work. And I think everybody has their sleeves rolled up and doing it. It's a big project, but I suppose I've learned from others, just because it's a difficult problem doesn't mean you can't solve it.
What I found, there's no one wants to block it and everybody's really supportive of it. But one of the, as I said, when we do research, we have our team of experts who are more than happy to, you send them an email, will you help us with this project? Will you become part of our steering committee? And they just jump on it. And the problem is you end up relying on the same people who, are interested and motivated. And to implement something on a national scale, you obviously have to bring people who aren't necessarily interested or motivated on board. And not because they don't care about CP, they just don't know a lot about it. And so I think that's, I suppose, been one of the frustrations on my part in terms of individual aspects of the programme, but also how I can already see it paying off in the long term is taking that time to build those relationships with stakeholders that don't know CP but are essential to making the programme happen. All these issues with CP we mentioned, when you tell them and they say, oh, I didn't realise, this is great to know, but without you telling them, they would never have identified a problem and they never would have tried to solve it. So that has been slow, and we've taken our time to build up those relationships, build a trust with people who aren't, as I said, in the area. And that is essential for embedding it in the system in the long term as well, because we already have people doing great work on the ground, but their problem is they can't get past a certain level. They do great work in their area, they meet a block, some kind of barrier, systems level barrier, because of certain policies where they can't implement it nationally. So we need to support them while they're working on the ground, but at the same time build that governance structure from this top to make sure there's no one going to block them in the future.
In terms of the family group then as well, and the advocacy group, would that have been linked with, let's say, the experience elsewhere, like the Cerebral Palsy, the foundation in New York, or was it sort of more innovative?
Advocacy is so important. And I mean, there's so many great examples in different conditions in Ireland about why it's so important, how it's worked. I draw a lot from a charity in the UK. I work with for adults with CP, and it's led by a woman with CP. And through her advocacy, just this week, she had an MP raise a debate in Parliament about services for adults with CP, citing all of our research. But they wouldn't be talking about my research if it wasn't for her raising it. And so I draw on that a lot to support the new family group in Ireland about that experience. And it is their group. It has to be led by people with CP and by families. But I suppose I can draw on that experience to offer advice along the way.
Yeah, to draw from what's been done elsewhere. And I suppose that was another interesting thing about the implementation, that let's say you would have studied other countries, particularly Scandinavian countries, is that right? As part of bringing the programme together.
You could talk about the registry in terms of that.
Yeah, there's, in terms of models of care, Sweden, Norway, the Netherlands, we looked at them a lot and we're working with them closely, particularly on the registry, but also they have kind of standards of care that they implement in, they've been implementing for 20, 30 years in their country, and we are doing it in some regions of Ireland, just not nationally. So and the nice thing about CP is no matter where you are in the world, everybody always wants to work together. So they've been so collaborative and so willing to share their learning with us. And so we working with those countries in particular around looking at the kind of model of care and how care can be implemented at a systems level. At the same time, Australia are so far ahead in terms of research and innovations. So we draw a lot from their work and work indeed with lots of researchers in Australia on bringing programs to Ireland. So specific interventions or programs that have worked well in Australia, how can we bring those and adapt them to the Irish context and implement them here?
And I suppose they're good learnings insofar as what could be done. But have you learned from other jurisdictions, let's say, things that shouldn't be done, or let's say things that maybe don't work as well in Ireland as have worked elsewhere?
For the interventions, there's a traffic light system, those that have a good evidence base, those that need further work. But to Jennifer's point, across Scandinavia, like orthopaedic surgery across Australia, pockets of the US, there's no point in us trying to reinvent the wheel and everything. We may as well take the best, like everybody has seen what's available abroad, and take the best rather than we don't have to start from scratch. We can look elsewhere, what's the best, and bring it into Ireland. And like orthopaedic surgery, and like I often cite that my single biggest achievement in life is that my son got the right surgery at the right time, that he got the right surgery when he was 9. And I say that was the defining moment of his life. There's no reason we can't have that here, but it's the specialist surgery. That's a very big intervention where they do orthopaedic surgery. And his was, I think, 13 procedures, at hip, knee and foot level. So it's a very complex gait improvement surgery. No reason we can't have that here. If you want to ask me across my life, what's my biggest is that he got that when the prediction was that he'd be a wheelchair user by college. I'm very proud of the photograph of him walking out of college. He's still an independent walker. And it's not that I have any problem if he was a wheelchair user. Absolutely no problem if that was his potential. I want him to be limited by his condition, not by the care he gets. And that's what I want. That's what we're trying to do, is to build the really good systems of care so that individuals in Ireland are limited by their condition, because they still have the condition. Like, there's no cure for the condition. They still have the condition, but that they're not limited by the system of care they get.
And there are elements to that approach as well, that it's multifaceted. I know we've touched on the early diagnosis, the advocacy group, but you're also developing the National Register as well at the moment.
Yeah, there's, CP registries have existed in some form since the 1950s. It's nothing new, and there's been, 4 if you include Northern Ireland here over the decades, and Northern Ireland is the only one that still has a CP register, and they have failed to continue because they've often set up an expert clinician with a real interest in it, and then they retire and there's no one to keep it going. So I suppose CP registers originally the aim was for monitoring the prevalence and profile of CP, really to understand what the future needs of the population are and to see how effective public health interventions are. And we know globally the prevalence of CP is declining, so public health interventions are working, and obviously improvements around neonatal care. But the more recent registries, which is what we're hoping, well, not what we're hoping, we are doing it in the process of, is they not only monitor the prevalence of CP, but they also monitor standards of care. So we do know some really good evidence about specific aspects of care, particularly monitoring for secondary complications. And there's really good programs happening. Again, Norway, Sweden, UK even have an established national surveillance program. We have it in pockets here. The registry needs to support that by monitoring our care against those standards. And without that, nobody's held to account. And it's not as telling someone you're not doing what you're supposed to be doing, but as a way of saying, look, at this region is able to bring its standard up to this level. Why is this region not at the same level? And why is that not happening? So that's the aim of the registry, and that's what we're doing at the moment.
Okay. And it feeds into the evidence-based treatment as well.
Yeah.
That's exactly.
And the other thing is, it's like all things in life. If you intervene early, as an overall cost for the health system, it's cheaper. Prevent. So the early diagnosis, early intervention during childhood, if you get the really good therapies, really good physiotherapy, the surgery will probably, it's not to say the child might need surgery, but it may not need as extensive surgery. But it makes total sense. If we're not to look at it from a moral point of view, let's look at it from a cost point of view. It makes total sense preventing problems rather than fixing problems afterwards. And for the individual, it's so much better, but also for the health system.
There is evidence of cost effectiveness from a few papers as well.
Yeah.
And in terms of, another element of the program is the fundamental thing, evidence-based treatment, and there are 3 clinical and research hubs. Would you see that growing as well beyond the program, or is it more so having the excellence in those specific centres and as well?
I would say that, we have 3 centres for the 3, say, Cork are looking after the 0-2s roughly, the infants in early childhood. Trinity are looking after children and adolescents, and then Jennifer, adults. They're the 3 centres, but it's implementing the infrastructure across the country, leading out from there. The ultimate goal is that Ireland becomes a world leader in cerebral palsy care and research, that we get to that standard and then we maintain it. I have seen things where we had good care, but we lost it. So it's one thing, we need to achieve it and maintain it, that Ireland becomes a global leader. And Ireland is a great country in the sense that 5 million people, generally a single health system, and particularly for children, there isn't really private care. And if we can get it right for Ireland, I think what we achieve in Ireland could be copied in other countries. I think within Ireland it could be copied for other conditions, but Ireland as a country, I would hope that other people are knocking on our door in a few years. We have a very ambitious, bold goal, but there's no reason we can't do it.
And just in terms of expanding centres, I think what we lost for PDS was that regional expertise, and what you've mentioned, bringing international perspectives here. When I spoke to our colleague in the Netherlands, who they have a recent CP registry, and I mentioned how it's going to be challenging because we have these 93 disability network teams, we have primary care as well. We need guidelines for CP, we need experts, and if you have one child with CP in every team across the country, there's no mechanism for building expertise. So although we have the 3 hubs or the three leaders, I think over time we definitely need to be looking at how do we build back in that regional expertise, because we can, and that is one of the aims of what we're looking at, particularly with the registry and a model of care, because we can't expect every therapist in every team to be an expert in CP.
And when developing that approach and system, I suppose, getting into the nitty-gritty of it, did you have a series of workshops together? Did you have a collaborative Google document or something, in terms of getting to those details?
Let's speak about Google Docs.
Not representing one more than another. Microsoft Word.
No. You go.
I think there's been lots of kind of formal and less formal conversations and going down rabbit holes. And CP is so broad, it's kind of where do you start? And, trying to define early on the scope and the boundaries of what we're working in. There hasn't been a structure per se. There's been regular meetings with the leaders But it's through that discussion and kind of pursuing one idea. Sometimes they don't always work out, but then thinking, okay, what's the next opportunity? And actually we've been pursuing several avenues during the early years of the programme. And really that's been so helpful to figure out, well, actually, this is how it's going to happen, because it's only when you start to explore the context and explore all the engagement and the stakeholders that you realise what's possibly going to work and where's the easiest avenues to go down.
Yeah, but I think it has worked very, well. We have it's sort of a structure, program leadership, collaborators, steering group, the family voice very much to the Cerebral Palsy Ireland now. We have the various structures in place. It's just the work, the volume of work, but I don't think anyone is work shy.
Yeah. And then as it's been rolling out, to put it that way, the programme, you have set up objectives, to put it that way. But is there a sense of also maybe having to manage expectations to a degree, or if that makes sense?
I'm more worried about overpromise, overpromising, and I want to make sure we deliver on everything we promise. So in terms of expectations, families, including all of us, would want it tomorrow,
Mm-hmm.
So in terms of managing expectations, it's Rome wasn't built in a day. I would much rather it quicker. That in terms of managing expectations, both for families and for ourselves. I want us to be very thoughtful that what we promise, we deliver.
And I think the one frustration I have, and like Lily said, if we wanted it done yesterday, if we're still working within systems of universities and of the health system where you're reliant on finance, contracts, HR, which there's multiple people involved in things that just to get projects off the ground can take months in times, and I suppose, because we know we want to register, we know what we want it to look like for years. We do have lots of interest in clinicians in it. And that's where we have to be really clear with our communications plan about making sure we keep everyone up to date about the progress and that it is a process. If we want it to be sustained in the long term, we need to put the time into developing it properly now so it's embedded within the system. And so I think lots of people are interested in it and want to hear about what's going on. And that is something that, not necessarily managing expectations, but managing communication with everybody so that they're all clear of the progress and where we're all heading.
Returning to that question I asked earlier about expectations, but the better way to frame it in terms of what I was getting at was the planning of the project, the implementation of it seems quite organic in one way, which has worked very well thus far. And I suppose would it be fair to say there's a sense of kind of not letting the perfect be the enemy of the good?
It's funny, I have that saying over my monitor, don't let the perfect be the enemy of the good. But we still strive high, for very high standards in what we do. I think we have a very good vision of where we're heading. Mm-hmm. And it's working, we have a very detailed plan as to how to get there. You know what I mean? Don't let the perfect be the enemy of the good, true, but at the same time, aim high.
Mm-hmm. And in terms of aiming high, I suppose one thing with aiming high is getting there. How are you maintaining the momentum to on that upward journey?
I don't think there's any problem.
Yeah. I could map out the next 10 years of the work I have to do for 10 years. There's no problem with maintaining. The problem is getting it all done.
Yeah, I think the biggest problem is just impatience. I'd say if we were to manage anything, it's our own, including me. It's all our own impatience. What's the plural of impatient is whatever. But that's keeping up the momentum isn't a problem at all, thankfully. But it comes back to a strong team.
Yeah, exactly. The team and the structure and clear objectives as well.
And no, I think that, and it's just KO, keep on. What's the saying? Keeping on.
And I to remind myself, and where Norway and Netherlands, where they have various well-established, health systems and very well-funded health systems. It took them 7 years in 7 years in the Netherlands to build their CP register. Norway took 5-10 years to build theirs. Sweden, it took them 10 years to become a national registry. So even in these countries, we're doing well. We're way ahead of that schedule. Yeah. And I think that's partly because we are working with the right people from early on, whereas in other countries, maybe they've started from the ground up and then they've had to bring people in from top down later on to make it sustainable. So when I get frustrated about how long things take, I think, okay, we're doing better than other countries and it will pay off in the long term.
If there was a group of people trying to create something like this for another condition or whatever it may be, what would be your key takeaways that you would impart?
I suppose in a way I'd nearly say just wait until let us do it, and then I'd be very happy to write our key takeaways. Let's develop and implement the model of care for cerebral palsy. Then we'll talk when we've done it. You know what I mean?
But even getting going, would you say, like even getting...
It's getting the right team, getting and working with families. Never lose the voice of who you're serving. And like I very much see us as serving families.
This podcast is sort of created with the spirit of sharing those learnings. And Dan, thank you very much for speaking to us about the program. Overall, do you think that there is a sufficient culture of that in Ireland for sharing the learnings, or do you think that it could be bettered?
What do you think?
I think maybe not specific to the program and sharing learnings. One thing I struggle with is that link between, so we have a PhD researcher on our team who did a placement in the Children's Services Unit in Department of Disability, Children and Equality, and just getting that expert knowledge, research, data into the right places is the biggest challenge, I think, and developing the structures around how to make that happen in the disability sphere, I think, is something I'd love to work on in the future, because it still seems disjointed about how decisions are made and what data underpins those decisions. Answering that question.
Yeah, like I think that's actually a very good point, is the data that, is there a good evidence base for decisions? Does the data support decisions?
Mm-hmm. And you drew on, let's say, the loss of specialisation previously. How can that be prevented going forward?
Well, I hope.
I'm asking for, it's like we go into the mountain to ask the...
Yeah. Well, I hope there's enough learned from, sort of that. Yeah. And like, in fairness to it, it was done with good motives, because it was done to try and make care equitable across the country. But in trying to do one thing, you can lose another. You know, you can gain on the roundabout and lose in the swing. And that's really what happened across the country. There are 93 teams, right? So people are connected, be it with CDNT teams or primary care, but lost specialisation. In any decisions that are made, where you do fix one problem, but the law of unintended consequences.
You can't operate with the fear of mistakes either.
No,
well,
absolutely. But it's to really think and really test what you're doing. Of course, because back to the perfect and the good, you have to move forward. But it's to really think out, and test what. It's almost risk manage change. When you're making big changes, what could the possible downsides to this be?
Do you think that the programme has trade-offs like that?
I'm sure it does, but we try to be very thoughtful on them and engage a lot. There's a lot of discussion.
Yeah. I think of criticism sometimes, and I get this for focusing on CP, even doing research just on CP, why don't you do it on physical disability more general? And my argument is always, it really frustrates me that we try to dilute individual people's experiences by trying to put them all into the one pool. So you'd never put children with diabetes and CF into the same pool. Why are we putting children with, spina bifida and cerebral palsy together? And it's kind of like you're expecting them to accept that, but you wouldn't expect other populations to be pooled together. And really, my argument always is, if we can, and it's proven in other countries, if we can get this right for one condition, it's shown, like in the UK, where they've done it right for CP on some topics, people with other physical disabilities have benefited from that. So
like it is focused on a very specific problem. We're focused on cerebral palsy. But I keep saying it is the most prevalent. So it's not as if we've taken something very sort of in a very small corner. It is if we fix it for that. But if we stay focused on that, then the learnings can be applied for other conditions. Like, I don't think anyone who said they did it all right from the start, it has to be fooling you. You know, like, if I were to go back, if I knew then what I know now, we'd have done things differently. But a lot of the things we would just repeat. In another period, I'd be very happy to share the learnings, and I would hope that there would be interest for other conditions.
Mm-hmm. And this was very much grassroots led by those with direct experience with CP and specialists in the field. Do you think that kind of approach then is beneficial, or could be beneficial throughout the health system?
I think the health system is even going in that direction. I think the health system has really gone away from the old medical model that clinicians know everything. Clinicians are expert in the condition, but families are expert in their child. So, like, if parent brings a child to an appointment, the parent is the expert on the child. The clinician is the expert on the condition. And the best outcomes are where they trade information and they work collaboratively. If it's very much being talked at, it just doesn't work. And I think within the health system, there's far more interest and support for that. And they welcome the voice of the family.
And generally, there's a move now with the new RHAs to integrate. I mean, there's always been that motivation, but maybe not the structures around it, academia with clinical care, and the idea of an academic health systems model. And that's proven across the world that needs to happen. And there's brilliant examples in Ireland where there's clinicians who also have part-time academic posts, and that's really where change has happened when they've had that. And so we're not doing anything particularly original, but that idea has never existed for CP. So unfortunately, when it hasn't organically built in terms of creating the academic clinical model for CP, this programme is creating that now.
And more broadly speaking, would you have any advice for somebody at an early stage in their career, might be looking to get involved with the health system or health policy, given all you've learned from this and other projects throughout? Would you have any advice for somebody in that position in their early to mid-20s?
Who wants to work in health policy?
Yeah, or the health system more broadly, I suppose health policy,
Well, I would welcome everybody, lots more people working in the health system.
I think particularly what we're lacking in our area is anyway people working on health policy. We're doing research on health services and on population health, and that obviously encompasses policy, but nobody's specifically working on policy. And that's really, personally, it's so interesting, because the problems with CP have often derived by the fact that they're not even mentioned in policy. If you look at adults with CP, there's a rare disease strategy, there's a neurorehabilitation strategy. They fall somewhere in between. So if they're not even mentioned in policy, of course, health systems aren't going to cater for them, and nobody prioritises them. So I'd love if more people maybe got into health policy, but specifically in CP would be very useful.
And in terms of charting that journey, that specifically in any walk of life, there'll be challenges along the way. In terms of weathering those challenges, would you have any advice?
Stick with it. Be tough. Just stick with it.
Yeah. For yourselves as well, beyond the program, I mean, is this kind of an end point when it's completed that you'll be satisfied, or do you have plans to build further?
I don't know. You never reach the end. I don't know. Again, it's probably a researcher problem. Once you think you solve one problem, you've identified 10 more problems that you haven't even considered. And really, with the registry, I see this as just the very start of long-term using data to change care, and also use it for research. So, if that could be part of what I leave as a sustainable registry that people are using for decades to inform care and research, that would be.
I'd be quite happy to finish when we've solved this problem. I'd be quite happy to retire a second time, and hope that my family don't divorce me in before then, because it's a big piece of work. But I think we will, to bring it to conclusion, and quite happily retire.
And there we conclude our chat with Lily Collison and Jennifer Ryan about the Cerebral Palsy Programme of Excellence. For our digest segment today, we're joined by Junior Dr. Beth Mallen. We began by considering the key takeaways from the interview.
For a bit of context, I'm currently in my basic specialisation training in adult medicine. And originally when I was asked to do this podcast, I thought that you were getting the wrong person on and you should get someone in PEDS training. And I think that was kind of reflected in what Lily, I think, said, that it was thought to be a childhood disability, even though the numbers they gave was that it's about 3,000 children in Ireland compared to 9,000 adults who have it. But everything I'd learned about cerebral palsy was taught in the context of pediatrics. And I think I was surprised to learn that there is no follow-on care into adulthood. That should have been obvious to me maybe, and that I'd never learned about it. But I guess I assumed because, as it was cited, there's a lot of follow-on care programs for kids with CF and diabetes, etc., to transition into adult care. I just assumed cerebral palsy, being as prevalent as it was, rather, would have similar. So that was really interesting to learn how much I didn't know and how much I had associated it as being a paediatric illness, when actuality it sounds like about 75% of the CP population in Ireland are in adult care.
I suppose getting into the nitty gritty of it as well, beyond the structure of the program, would any particular part or parts of the interview inform the general approach of a junior doctor?
I guess in terms specifically in relation to cerebral palsy, I would have been involved in care of patients with cerebral palsy in the adult population, in that if they came with something that would be considered general medicine, so example, an infection like pneumonia, etc., I'd be involved in their care. But we'd be quite conscious on the general medicine side of things not to intervene in what we'd consider their aspects of specialist care that I guess I presumed that they had, when unbeknownst to me from the interview, it sounds like it's the GP who's managing a lot of those in the community. So maybe it would inform me that actually there's a lack of specialist care going on or I suppose the specialist care is being governed by the GP, so that maybe there is scope for general internal medicine practitioners in the hospital to take more of a role in dealing with some of those things if they think that they have appropriate interventions, rather than saying that's a specialist matter when that specialist care might not actually be given in the first place.
It was touched on sort of throughout the interview at several points about the importance of specialism, and then how do you approach it, because there was this, I don't know if you've got that sense too of having to balance maintaining specialism but also making sure that there's broad access, provided.
It was interesting to hear about the restructuring of disability services in Ireland. Again, I wouldn't. I think they're mainly children's disability services, so I wouldn't have a lot of knowledge about it. But I do remember when I started my pediatrics rotation in college, hearing one of the pediatricians talking about the restructuring and expressing dissatisfaction with the fact that they felt they weren't asked about it, that people who use the services weren't asked for their opinion on it, and that they felt that it was a mistake to remove, as Lily and Jennifer said, the paediatricians, the dietitians, etc., from the model of care. I get that they're trying to widen it. I think they said there's now like 93 community teams. So you're giving widespread access, but I do think it's an inefficient use of resources. As Jennifer said, if you have one child with cerebral palsy going to each of these different centres, there's no specialisation of care there. They might not get the quality of care that they need. And you're not building that regional expertise that they were talking about. I also think that, especially for a country as relatively small as Ireland, I don't know that, now obviously I haven't tried to access this care, so maybe I'm wrong in this, but I don't know that the regional centres of excellence stopped access of care. Like, I get that there might be travel constraints, etc., but I think when you're talking about specialist care, it's not on a necessarily like a weekly, monthly basis. It might be quarterly, it might be annually. That might be something that people are willing to travel for to access that specialisation.
Was maintaining that in the approach to how these programs and similar sort of health systems are devised. There's a balance to be struck between them. But would you see kind of them more generally that there's there could be a risk of loss of specialisation in certain aspects of the healthcare system?
Well, it sounds to me from the CP side of things, hearing Lily and Jennifer speak, I would say that there has been a loss of specialisation. And I do think you risk that if you were to follow the way that the disability model of care has been restructured in Ireland. If you were to implement that in other areas, I think you probably would lose specialisation as well. From a medical perspective, so the way that specialist training in medicine is structured from, for example, an internal medicine point of view, a lot of clinicians are dual trained in a specialty and general medicine. And within that specialty, they do further fellowship, specialisation, etc. So the way the way the medical field is going, it is increasingly becoming specialised, not to the detriment of general care, but I think in a way that benefits patients. But the problem that they seem to be outlining in the interview is how you access that level of specialist care, because it seems like medicine, definitely from the way I'm being taught to view my career, is focusing on specialization, but the way maybe health policy is going, it's focusing on broad access. So it just lends the question of, we have this degree of specialization, but how is anyone able to access the care it should provide? An interesting thing, when you ask me about things like specialists, non-specialists, I think a junior doctor, especially at my stage, so I'm just finishing my third year of practicing post-college, I'd consider myself very much to be in the non-specialist category. Admittedly, I'd have more knowledge than the average person approaching a project from a non-medical perspective. But medicine is so specialized, and the experts they're talking about, professors, etc., like the difference in knowledge, the scale of it is such that I would actually consider myself very much to be on the non-expert side of things.
When training as a doctor, is there an emphasis on working within the system then, or is there kind of any talk about improving the overall system through mechanisms like that program?
It's interesting because one of the only times I can remember hearing about it as a student was actually from pediatricians on my pediatric rotation in the context of the disability services restructuring. You definitely learn about the limitations of the system or working within the system when you start working in the hospital. So, for example, on general medical call, we'd call it, which would be you're the out-of-hours doctor, you're admitting patients from the emergency department who've been referred to you for admission. A lot of what we get referred wouldn't actually be people who need an admission in the acute sense. This isn't something that they need immediately dealt with, but it's a problem that we have no way of getting them the care for they need in an outpatient setting. So either we could refer back to the GP, for example, and they could refer, but be waiting up to a year, and this is the problem that they can't cope with living with for that length of time. Or it might be something that we think is like, actually, this is like a subacute issue that needs to be dealt with in a timely manner, but we don't have a quick pathway for that. That's definitely something you become aware of, because you're doing admissions that you're aware of are costly. To be totally honest with you, when you're doing them at 3 a.m, they don't feel like something that's very acute. You become a bit, this is ridiculous. There should be a better system for this to avoid this. Obviously, the patient doesn't want to be admitted to wait several days to be seen by a specialty for something that could have happened in an outpatient scenario. It has led to different innovations. So in the hospital I'm working in, there were different pathways set up that allowed for ED referral to these things. And they used a HSE Spark funding was an initiative that people could apply for a small amount of funding to start these pathways. So different examples where I think in the hospital I was in, they implemented a first seizure pathway. So whereby someone presents with a first seizure or a breakthrough seizure, if they're known epilepsy, they could be seen by the epilepsy specialist nurses very quickly after discharge from the emergency department. So that would save for an admission. Similarly, if someone has atrial fibrillation and comes in, new diagnosis of atrial fibrillation, they could be seen very quickly in the outpatient clinic. Similarly, severe headache, rapid access headache clinic. So they all started as admission avoidance tactics in an efficiency way, but lead to good access to care.
Overall, then, taking a step back as well, how might launching a similar program to the one that was launched for the Cerebral Palsy program, how might launching a similar program for another condition differ from the experience that Lily and Jennifer outlined, especially, let's say, if it was led by somebody who's at an early career stage in the medical sphere?
So this was something that I was kind of aware of listening to the podcast. The way the medical career flows in Ireland, I think there is such a degree of instability in terms of location. So we move jobs as frequently as every 3 months, but kind of up to a minimum of yearly. There are obviously exceptions to that up until we become consultants. So you're actually not in one place for a very long time, such that when I originally started in a role, one time I wanted to do a bit of research and I went to a consultant who was supervising me, and they advised me against what's called a quality improvement project, because I wouldn't be there long enough to see the whole thing through. So if that's on the basis of within one hospital, you're not going to be there long enough to implement that, trying to maintain connections for long enough to implement a national strategy would be very challenging at a junior stage of a doctor's career.
Okay, you'd have to have some sort of external element, as well, like there was in the Cerebral Palsy program.
Yes, And even I found it interesting that when they said that they'd managed to get philanthropic funding for dedicated roles. And I was like, that's going to be the thing that makes the difference, because you do hear so often things like, oh, there was a consultant who had a very special interest in this, like in the Northern Ireland Register, they maintained the register, they retired and there was no one to take it over. That's really common in medicine. So having dedicated roles that don't rely just on people's interest and goodwill is really important. And maybe from that perspective, it could be that junior doctors could get more involved with existing frameworks, but I would find it very challenging to conceptualize how you'd come up with a framework and how you'd go about implementing it when we move as often as we do.
What's interesting about your particular position as well is that you're between top down and sort of bottom up. You know, how do you think that could be balanced?
I don't know if there is a good answer to that. Oftentimes, the quality of what you can achieve in terms of trying to start research projects, etc., is going to be dependent on the quality of the consultants you're under and how much research, or how much, I suppose, input they're willing to give you, especially for something like this in terms of establishing like an interdisciplinary thing. You would need their connections, I imagine, to make anything meaningful happen. That's something that you just wouldn't really have at a junior stage in your career.
Yeah, and there was a sense as well that people are important throughout the process, both getting specialists on board, but also there was a sort of an importance of engaging non-specialists within the system. And do you think that the system is conducive to that kind of interdisciplinary and communication and collaboration?
It sounds from the effectiveness of what they've pulled off with this project that it is possible. I don't know how much that actually comes into play. I suppose when we say in the system, is this when the state try and do something? Is this because this seems like a grassroots movement that then got state support? I don't I think that a lot of successful initiatives in Ireland have been grassroots, in the sense that they've come from family groups like Down Syndrome Ireland, Cystic Fibrosis Ireland, now Cerebral Palsy. And that's led to a good kind of, I suppose, input from non-specialists and looking at the lived experiences of people. I don't know if the HSC itself or the systems they put in place have that focus, but admittedly, I have never tried to do anything like this. So this is possibly quite cynical of me, and just from and just if you ask me gut feeling, I'd say probably not. I'd say they would be better formed by grassroots, and then the state gets involved. And
I suppose it's not, it's an oversimplification really to say that there's just the one system. I mean, there are several within it, and then you create your own systems as well throughout the process. I suppose you touched on something there too, in terms of if a junior doctor was looking to make a significant positive impact, then how are they guided towards that?
So research is a really big focus. You can't really progress in your career without it. It sounds like a way to make a really big problem would be to get involved with something like what they were talking about, say early interventions, early recognition of different conditions, and you could make that your research focus. Some doctors choose to do, and it's kind of expected in certain specialties, that you'd choose to pursue a qualification like an MD, so essentially a PhD in medicine, or whatever field of medicine, surgery, etc. you're doing. And you could probably, given that that's like normally done over 2 years, you could probably choose an area that you think needs more better pathways, etc., needs more research, and choose to focus on that. But again, that depends on where you're going to get your funding from. There's a lot of things outside of your control in that. But yeah, I think getting involved in research that's probably being led by other people is probably their best bet.
And that brings us to an end of this episode of Memo to File. Thanks to Lily Collison, Jennifer Ryan and Beth Mallen for joining us, and indeed thank you for listening. A transcript of the show is available on Substack at Memo2File, and our email is memotofilepodcast@gmail.com. On our third episode, dropping next Thursday, we'll be exploring the Global Crossing Transatlantic Fibre Project with Brendan Toohey, who was former Secretary General at the Department of Energy, Communications and Natural Resources. We'll also be joined by Conor Igo for our Digest segment. See you then.